All right. So thank you very much. I'm sorry for the delay, Dr. Nazrullah Khan, because unfortunately this talk did not reach me, and so I just had to open. So we'll talk about actually how we go about pre-procedural evaluation and for a TAVI. So there are several designs that are available, several types of valves, self-expanding valves, balloon expandable valves. The one on the right side, the lotus edge valve, was also a different type of valve that is mechanically can be released, but unfortunately it's not there anymore. Okay, so there are several valves that came out and never made it. And so the ones that we normally use in our lab is actually a balloon expandable valve, which is approved in the United States, called the Sapien valve, that carries about 40% of market share in our hospital, and 60% is the self-expanding valve, which is the Evolute Pro Plus FX now, Evolute FX. So when does the pre-procedure planning start? The screening starts when the patient is walking into the room. And I actually want to see the patient walk before we offer a TAVR. If they're coming on in a wheelchair, I still want to say that maybe can you take few steps and look at their either 6-meter walk test, 6-minute walk test or 5-meter walk test. We do that. And so they need to have some sort of frailty, meaning they're truly frail. And are they frail from the valve, or they're frail from other comorbidities that will not change even if you replace the valve? So there is always a different definition of about futility. When do you want to take the risk of a TAVR? Is a patient not a patient is almost dying. Don't offer this as a even though we have done it in patients who are admitted with acute heart failure. You first actually have to manage that before taking care of the aortic stenosis in the type of patients. So there is something called futility. You know that whatever we do, these patients who are very elderly may not survive. So I have seen a patient who came at the age of 96, and she has severe aortic stenosis, and we talked about it, and we said that I offered her TAVR. She didn't want it at that time. She came back at 98. And at that time, she was very sick and she wanted TAVR. We got her out of the hospital after treatment of acute heart failure. And then she went home, came back for the TAVR, and survived for another. She's still alive, more than 100 now. Okay, so so frailty is not. I think it's a very simple test. It's like 5 chair rises with less than 15 seconds. And if it requires more than 15 seconds, it is 1 point. So I think as we grow towards westernization, we become frail. You please understand that. How we used to eat when I was a kid, we always sat on the floor and ate. Now we sit at the dining table. Now westernized toilets, you don't kneel. So suddenly getting up out of the chair without holding on anything itself is a test. How many of you can bend and squat completely and get up within a short period of time without holding on anything? So that's a test that you should do. Even I think, I'm now more than 50, so I keep doing that actually to check whether I'm frail or not. Otherwise you have to exercise very well. Cognitive impairment. There's no point in trying to take care of a patient with complete dementia and saying that, oh, he has aortic stenosis, let me put a valve. That's not fair, So he is not going to improve. He is not going to survive that long. Hemoglobin and serum albumin, if they are low, they are risk factors for frailty as well. So frailty has been shown that if you calculate the frailty score and whether it is a SAVR, surgical aortic valve replacement, or TAVR, they may not do quite well, so if they're frail. So these are the things that you need to understand, and we shifted as we grow along with the TAVR program. Everybody used to get coronary angiogram before. It's important if they are less than 75 years of age. Now, actually, if patients are 80 and above, we are not doing coronary angiogram on them anymore unless they have ischemic symptoms. Because unless they have ischemic symptoms, there is no need to treat the coronary artery disease. So, younger people do a coronary angiogram, understand the significant coronary artery disease. If it is left main or proximal RCA disease or proximal LAD disease, you treat them before you go to TAVR. And if a patient is eligible for surgical aortic valve replacement, maybe bypass surgery is required. Aortogram, again, we are not doing that anymore because we do a CT aortogram. Aortoiliac angiogram, that also we are not doing anymore because we depend completely on CT. Now our protocol is that we do a CT all the way from the jaws to the femoral arteries, or a little bit into the thighs, SFA we look at. So that actually gives us whether we can do it from the groin, femoral axis, transfemoral, if it's not possible, whether subclavian or carotid. Our alternate axis, if it's not transfemoral, is actually right carotid. That's our preferred alternate axis that we use. So this is a coronary angiogram. Treat coronary artery disease in younger symptomatic patient. Treat aortic stenosis first in older, diffuse, and asymptomatic patients. Okay, very simple. Try to simplify these things because you want to concentrate much time on the TAVR itself. The annular sizing is very crucial to procedural success. In the beginning, when we started, I started TAVR in 2009, or first 2010 January or something. So it was very difficult to size the annulus. We used to depend upon TEE, and CT scans were not a gold standard. And placement of valve is, the size of the valve is not very good. And so, but now CT scan is a gold standard. And the new valves right now we use have actually a skirt that prevents the paravalvular leaks. And important to be meticulous with annular measurements. And echo is an adequate screening tool, but TE must be performed if there are any questions. So we still do a lot of TEs because low-risk patients don't come to us because we are a tertiary center, quaternary center, and a heart transplant center. So all the patients that get referred to us are very sick patients. And the young low-risk patients actually go to other centers which can do TAVRs. So the variability in measurements with the transthoracic annular measurement, if you do a TEE and if LVOT or annulus measures about 19 millimeters, you can add if you do a TEE, it will be at least 1 millimeter higher. So the annulus is always underrepresented in the transthoracic echocardiograms. Even TE is not the best, but if you do a CT scan, that actually gives the entire cardiac phase and a systolic 20% or diastolic. You can actually measure about 20 to 30% in systolic. You can get the right measurements of the annulus plane of the annulus. And the valve bicuspid, I think Dr. Pradeep is going to talk about the bicuspid valves and other challenges. Bicuspid, the significance of calcium. We actually now calculate aortic valve calcium score. And we give, just like a coronary calcium score, we give a aortic valve calcium score. If the calcium score is more than 2,000 at our center, we traditionally do a balloon valvuloplasty for all the patients. If it is less than 2,000, we don't do balloon valvuloplasties. And the amount of calcium as well as where the calcium is will also give us an importance for whether there's going to be a paravalvular leak or not in these patients. And so you can expect some paravalvular leak in bicuspid, like this patient who has a calcium score, very bulky calcium only on one side of the valve, and the fused raphe. So it is important to know that. And outcomes, I think I'll skip that in bicuspid. We'll talk about that. So the paravalvular leaks, as you can see, that is the reason, because we are putting a circular valve in an oval-shaped aortic annulus. So you can never seal that very well. So, and there may be still some leak, paravalvular leak, and we have to see how much is it. The number of paravalvular leaks compared to SAPIEN XT or original SAPIEN valve, and then the next one was SAPIEN XT, and then initially core valve. Now actually the evolute, all of them have actually about 5% or so paravalvular leaks now. The other complications you have to think about whenever you do a TAVR valve is also expect some complications, and how can you prevent it and be prepared for it. And one of the complications is left main coronary obstruction or any coronary obstruction, and then you need to calculate where the sinuses are, how large are the sinuses, in the sinotubular junction. What happens is, if the valve, you're introducing a valve into the old valve leaflets, they open and close, right? If they're pushed towards the ventricle, there's no problem at all. If they're pushed out into the aorta, then there may be a problem. Because if the ostium is right here, the native leaflet will be pushed and go against the coronary ostium. So the height of the native leaflet to the height of the coronaries is important. You can implant the minimum for all of you who are starting. The length, height of the coronaries, anything less than 10, be very careful. Okay. And have I done in 6.5? Yes. Even 6.5 millimeters coronary height, I have done it. But you need to expect. You might sometimes have to put a wire and even a guide liner into the coronary artery to protect it. And but if the sinuses are large, the sinotubular junction is large, and then you don't have to even protect it if you're comfortable. So, but you need to understand those nuances that are there with how the valve behaves. So coronary heights from the annular plane on the CT scan, we draw a line and measure to the bottom of the coronaries, and then you can also measure from here to here. You can measure the leaflet height and see what happens, and you can think about that. Coronary obstruction can be deadly. So if you have a coronary obstruction like this, the patient is going to not last that long. Immediately you need to open it up and open. So this is as you can see, a valve-in-valve procedure we were trying to do, and immediately coronary obstruction. The first thing that went in is actually an impeller, because otherwise the patient is going to have VFib arrest and die. Actually, his patient had a VFib arrest. So then you can take your time to open that coronary artery. And how about the assessment of the patients? You can use, as I mentioned, about MRA, but we always depend upon coronary CT angiogram, or CT angiogram for the TAVR protocol. And you can determine the iliac vessels based on with the angiogram or a CTA. And if the patient has chronic kidney disease, we avoid contrast overall and actually use non-contrast CT, and with that itself we can actually see the size of the coronaries. But the annular sizing becomes difficult without the contrast. So what we do is we put in a small pigtail catheter into the aorta, just like for an aortogram, and send the patient for a CT scan and inject about 20 cc plus another diluted contrast, so total 40 cc, 1:1 dilution, and inject 40 cc of contrast and do the CT scan. That will give us at least, with a minimal amount of contrast, we can get the annular sizing of the valve correctly, and non-contrast for the peripheral is all right. So the basic guidelines: choose the side with the larger caliber and less tortuosity, and with the right femoral or left femoral. Lower the bifurcation, the better it is. High bifurcations have again complications. Lower bifurcation, less tortuous, and larger femoral size, femoral artery should be picked. Observe for any significant lesions. We sometimes now, anything less than 5 millimeters is not recommended for evolute valve. Anything less than 5.5 millimeters is not recommended for a balloon expandable valve. So, but if it is still less than 5, I think next Thursday I'm going to go and do femoral TAVR with a 4.7 millimeter dimension in the femoral artery. But I'm going to use a shock wave in that patient. And so you have to have a plan. Look at the CT analysis and determine what calcification, where exactly, and whether it can be, you can just push in a dilator or do a balloon angioplasty or shock wave. So one of these three things you have to pick. So these screening MRA or CT scans are very helpful in determining and learn. You have to learn now how to measure all the dimensions by yourself, and you don't have to depend upon other people. If really in chronic kidney disease you want to use ultrasound, you can use ultrasound. Because I'll show you one thing that actually, this is my worst complication. We call it an artery on a stick. You can actually cause damage if you choose. In the olden days where we needed 8 millimeters, and this patient's artery was about 7.8 millimeters. And but we thought there's no calcium, nothing, everything went well. And I was proctoring, And I told them that, okay, it's, be careful while removing the sheath, because just like a radial, probably you might have seen radial spasms, right? When sometimes the catheter doesn't come. What do? You take your time, millimeter by millimeter, you have to pull it back. So if you pull back suddenly, this is what happens. The radial artery can also come out with a catheter. Here it's an iliac artery. Radial artery, patients will survive. Here the patient will die right away because they bleed to death and there's no way to stent anything, So surgery actually can save them. So general anesthesia, no general anesthesia, depending upon the risk of the patient, the experience that you have in your center, and whether you have an echocardiographer and an anesthesiologist or not. In the beginning, I would say that everyone should have an anesthesiologist in the room, and they should assess, they should be available to intubate right away, and especially in the lower risk patients, probably it is not a bad thing to even do without general anesthesia. So new valves and the new technique, most people are shying away from general anesthesia. It is done with the moderate sedation. So how do you prepare your lab? Make sure you have 2 units PRBCs should be available in the room. We don't start our case unless the blood is in the room. Actually, we are not allowed to start. And so, we can just sit around and wait for the blood to come before you stick the groin. Radial artery line and central venous line placed by anesthesia. Defibrillation patch should be placed on all patients, and patient is intubated by anesthesia. Bilateral groins are prepped and draped, and the backup arterial access needs to be planned. If you cannot advance the sheath from the right groin, you need to have another left groin or a carotid, whatever your bailout. You should have a plan, and you should mention that. And that should be part of your timeout when you say that this is what I'm going to do for the patient. And the right heart catheterization is performed in people who are sicker, but not in all of them anymore. So the patient selection depends upon increased operator experience. As I said, initially take low-risk patients. Even though the TAVR studies looked at the way we started, our partner 1B and CERT-TAVI trials, we took the sickest of the patients. And then so we said, okay, these patients are going to die no matter what. So inoperable patients, do TAVR. Then intermediate risk patients, do TAVR. Then low risk patients, do TAVR. That's how the studies are done. But for all of you, start with the low risk patients and then keep increasing to the high risk patients. And the pre-TAVR imaging, 3D TEE and CT scans are recommended. Adjunctive techniques help to control and manage catastrophic situations. Now you have to be a peripheral interventional cardiologist. Obviously, you still have to have skills of accessing the coronaries, and depend upon the surgeons for carotids or subclavian or transcaval if you have to do. And a heart team with knowledgeable and complementary members is very important. So just one couple of slides on balloon expandable and self-expanding valve versus local anesthesia versus general anesthesia. It's a 2x2 design in this now beautiful study. There's no difference between any of the primary endpoints between self-expanding valves and balloon expandable valves. Even anesthesia, there's no difference between local or general anesthesia as well. And all-cause mortality, there is no difference even up to 5 years in these patients. So, and pacemakers are slightly higher with self-expanding valves, but that has come down with now we use something called cusp overlap view, and we place the valves much higher. I think in the next room there is a demo that you can actually implant the valves in a model, and then you can see how high you need to implant. And there are several risk factors for why you need pacemakers. Nowadays, when we see a bundle branch block and a first degree AV block, we send the patient for EP evaluation right away, and they get the pacemakers. So core valve was higher, Evolute is much lower, Sapien XT was lower, Sapien 3 is higher because they got a skirt around it. So if you look at Evolute and Sapien 3, there's no much difference between the pacemaker use. And the depth is important because the membranous septum is where the IoT AV bundle is, and if you block it with the device, then you can go into heart block right away. So peri-procedural AI is dependent upon both hemodynamics. In my lab, if I implant and I am looking at a PVL, and there is a PVL on the echo, they say, oh my God, there's a moderate PVL, and blood pressure is diastolic is 55, I'm not going to go after it. It'll get better. You leave it alone. If the blood pressure is less than 50, I might actually consider ballooning the valve again. If not, I don't do it. So multimodality imaging is the key for analysis of PVL. I think the best one is a gastric, transgastric view to look at almost like apical 5 chambers. That'll be good. So AR index can be calculated as well in a patient with moderate PVL. AR index is actually diastolic pressure minus left ventricular and diastolic pressure divided by the systolic pressure. That's why the diastolic pressure is important. If you think in this calculation, ultimately, I feel that if a diastolic pressure is 50 versus 65, it makes a difference, and that AR index will be better. So lower AR index, I think obviously it is been validated, and if there's lower AR index, the survival is also lower. So I think with that I'll stop here, and the patient selection I think has understood that you may want to take people who are in India, and here I see that nobody wants to spend a lot of money on a TAVR in a patient who is 80-year-old. First they'll think that we are after their money, so they look at us, so we are crazy. So likewise, people who want to, but still be very clear, complications are few. My patient, I always explain it this way. I know in this part of the world, explaining that way is not very good. I tell my patients that the risk of stroke is about 2 to 3%. The risk of dying, we calculate it. Actually, there's an app called TAVR in-hospital risk mortality app that you can calculate. But it's about 1% or less in hospital mortality in TROP. So, and risk of pacemaker is about 5%. But for a given patient, if it is 100 people, yeah, that's one person might die. But for a given person, it is either 0 or 100%. You might think that everything is going to go smoothly. Something might go wrong. You need to be prepared on how to handle that right away. Okay. Thank you.